I think that now, finally, we are fortunate to have several other new agents in development for patients with PTCL. And there's a list of them, but we're just going to ask with experience, maybe Steve, you have any experience with belinostat, another HDAC inhibitor?
So belinostat's another HDAC inhibitor that completed a 100-plus patient phase 2 study, and those results were presented last summer at ASCO and at the Lugano meeting. Similar activity to romidepsin, about 25-26% overall response rate. As I mentioned earlier, particularly high response rate, almost 50% in the angioimmunoblastic subset. This drug was given IV daily for 5 days every 3 weeks, so a lower single dose. There's some sense that some of the hematologic toxicity was a bit less than romidepsin, and patients do get that, that extra week break. Again, I think like other HDACs, single agent in T-cell lymphoma, a minority of patients respond, and in those that respond, you can maintain some of those responses, but really in trying to impact the disease overall, we'll look at this drug as a potential combination partner for other things.
How about another class? How about dasatinib, an experience with
Yeah, there's a small study out of Nebraska, I think it was Nebraska Mayo, that was presented at ASH a couple of years ago now, where there's a few responses in patients with T-cell lymphoma, including things I've heard anecdotally, that a couple of those responses are going on at multiple years. Hard to know what to do with that, but it would be interesting again to see if there was some predictor in those patient samples as to why those patients were particularly good responders. So there's an idea there, but very little data.
Have you had any experience, or do you know about, we've talked about, say, in the PI3K inhibitors now, a lot of them are just the delta-specific inhibitors, but there's an IPI-145, which is a gamma delta. Do you have any experience in the T-cell malignancies with that?
Yeah, so we've been working on that study of phase 1 with expanded cohorts with that drug, and we presented some data at ASCO last year. I will say that T-cell receptor does signal through PI3 kinase delta, but the gamma may bring in some more cytokine or other issues that may be more important for T-cell responses. So what we presented at ASCO were responses kind of across the board in lymphomas, including a subset of T-cell lymphomas. I think we had 9 at that time, and we're up to about 30 now. That study will be finished soon. And what I can say is that we've kind of seen responses sort of across various subtypes of peripheral and cutaneous T-cell lymphomas, and it's an early study, but I think those drugs will have a role or may well.
I think I'd like to ask Anas, what about your thoughts on the pan-class 1 PI3K inhibitors? Do you have any comments?
Right, so it's too early to call which PI3 kinase drug will be the winner. There's advantage and disadvantage for either one. So the advantage for the more specific is less toxic. Right. But there's now more data that suggests that if you inhibit one enzyme, there is a compensatory mechanism where the other enzyme kick in and provide signaling through the same pathway. So there is a theoretical advantage of inhibiting more than one enzyme, so pan-class 1 or alpha, delta, and so forth. Those will need to be tested in a clinical setting to find out whether this preclinical concerns will translate into a clinical setting. Clearly, if you use a pan-class 1 inhibitor, you have more toxicity, especially with diabetes and rash and so forth.
Sure. Thank you. Well, we've had a lot of interesting discussions, and I think we've touched on a variety of issues today, and I'd like to thank basically the panelists sincerely for your insights. And before we conclude, I would like to ask each of you for any final thoughts or any pearls for our colleagues and listeners who are involved in the treatment of hematologic malignancies that we've discussed today. So why don't we just throw that out, Dr. Horowitz?
Yeah, I think the positive and the excitement in this field right now is there's a lot going on, and you feel legitimately in B-cell lymphomas, and I think in some of the other diseases we've talked about today, that we're really kind of at a pivotal time where we're seeing paradigm shifts, and we're seeing new drugs with activity in multiple lymphoid malignancies that have fundamentally different mechanisms of actions, and I think that gives you a lot of excitement and a lot of optimism for the future, and we've talked about that a lot today.
Thank you. Anas?
So I agree with Steve. It's a really exciting time for patients in medical oncology field. There's a lot of drugs being tested. Many of them have some single agent activity. I think the next step is to start to match patients with these drugs by finding some pre-selection criteria based on genetics or biomarkers and so forth, and also start to extend these treatment strategies into minimal disease. In the past, our assay of measuring minimal disease was very primitive, never been helpful in clinical setting, except with few exceptions. I think now the science allows us to detect minimal disease in ways that we couldn't be able to imagine that we can do it, and then hopefully will open the door for newer treatment strategies targeting minimal disease in the future.
Lauren, any final thoughts?
I think for those of us that have been doing this for a long time, the time has finally come where we might have our wish and not have to give chemotherapy. And perhaps in the future, instead of us breaking up into segments about Hodgkin's and T-cell lymphoma, we'll be breaking it up into segments on pathways that are overrepresented in certain disorders and what targets we have for that pathway, and really changing the paradigm of how we look at lymphoid malignancy.
It's not treating a specific malignancy, treating the target in the
Right.
malignancy. That's a very good point. Andre, any final thoughts?
Yeah, I'm also very excited about all these new agents that are coming out, especially for T-cell lymphomas. I'm more intimately involved in T-cell lymphoma therapies and research. And where we didn't have any agents 3.5 years ago, we now have 3 approved and 2 on the brink of approval, and several of them show remarkable activity. I'd also like to make a plea to community physicians not to jump immediately on phase 1, phase 2 data, and potentially consider sending patients for well-organized clinical trials so we don't lose these initial discoveries, because once the drugs become available and used broadly off-label, we lose the patient population to further develop this this initial clinical developments and clinical studies. So it's very, very important to remain patient, but keep your mind open and utilize research vehicles to advance this knowledge.
Excellent point from all of us, from the panel. So on behalf of our panel, we thank you for joining us today and hope that you found our peer exchange informative. Thank you.